I'm Kristen Peterson. I'm one of the pediatric nephrologists at the Children's Hospital. Leilani is a pharmacist that has joined the project since we got the funding. And Jarrett McKittrick is one of the heads of pharmacy who was one of the people that were involved in creating our sort of pitch to the group last year. We last met with any of you the day that we were trying to say why we wanted you to fund us, and actually haven't had an opportunity to say thank you. So I want to start by saying that. This came at us we wanted to move this project forward and didn't have funding for it, and then went through this very creative process, thanks to all of you, to move forward and to get funding for this. And Leilani and I have started working together in January, and we're just going to tell you a little update on what's been going. For one thing, we changed the name. Saying first do no harm constantly on the wards to try to tell people what we were talking about wasn't working very well. So it's now been changed to SPOT AKI, and SPOT stands for the Surveillance of Patients on Nephrotoxic Medications for Acute Kidney Injury, which rolls off the tongue a lot better as a shortened thing than first do no harm is. So just to review what our project was about, we wanted to develop a screening, monitoring, and eventually a follow-up program for kids that are at risk of getting acute kidney injury, so harm to their kidneys related to medications. The medications are often ones that they need to be on for various reasons, but when we put enough of them in combination or a duration for certain medications, we cumulatively increase the risk of them getting acute kidney injury. And this is a hard thing that happens in the hospital because they start on a medication, we add another one, and people don't necessarily put those things together. So we wanted to have a screening system done in the pharmacy to identify the kids that are at risk and point that out to people. So this is what the background of that is about. So what our process is that we're screening patients at risk of AKI, and we've started doing that already in a pilot form. So far, we haven't activated anything yet on the ward. The pharmacist will review which children are at risk of AKI related to the criteria of being on more than a certain number of medications or certain combinations or specific medications. That will then be told to the inpatient teams that are looking after the children. And then we go on to screening, which I'll get to in a second. So this is just the preliminary data. We were asked a lot last year about how many kids are we talking about that actually have this risk. So we looked at a bit of data in December before we started doing anything in January, just to get numbers of patients that have in the hospital that have some risk. There were 53 patients that were pulled up in the system in that month that were flagged to have a potential risk. Some of them were eliminated because the medication isn't nephrotoxic medication, but it's being given on the skin, and the risk isn't really there because of that. So there were 36 patients in December and 39 patients in January that would have met this criteria and would have followed through on the screening. So there's a reasonable number of patients that we're targeting and hitting by looking at this. So once the pharmacists have identified this, the plan is that they'll go to the ward teams to tell them about there's a patient on their service that has this risk, and we've developed a screening algorithm to alert them to what they need to do, which is basically to check their kidney function and to do some other monitoring. So this is one of the forms that we've now created that's still sort of in draft form, but we're getting close to the finish line on finishing this, to tell them these are the medications, this is what caused the risk, and this is the screening that we're expecting you to do. And if they have a high enough risk category, then they would be consulted to nephrology, but not all of them will necessarily need that. The next piece is we'll be looking at them in the hospital and seeing what their concerns are and monitoring them. And the final piece to our project, so we've talked about screening, we've talked about inpatient monitoring, and then the last piece of this is making sure these kids get followed up. If you've had an AKI risk, there's a risk of chronic kidney disease down the road, which we want to prevent if we can, or at least ensure kids are getting appropriate follow-up. So this sheet has been developed to get sent back to their primary care providers, their pediatrician, their family doctor, sometimes other subspecialists, to make sure that the loop is closed, and if they've had an AKI episode, that they're reassessed again to see if they have any risk, because some of it's modifiable if we identify if they have it. So this is also something that's been developed as part of the project. This is an information sheet we've developed to give to families at discharge if their child has had an AKI episode, so that they know what we're talking about, so that they understand what's happened to their child and what we're looking at in terms of why we need them to come back and have this screening done down the road. So our progress so far has been creating all of those with a lot of feedback from other services. And then we've been having meetings with the inpatient groups and also talking to some of the primary care providers of how are we going to get this follow-up piece done. What we've discovered is that the screening in the hospital, which was the whole impetus to start, seems like it's the easiest part to get people to buy into. It's really trying to figure out how to get the follow-up piece done. That's going to take some creative work. With all the EMRs that people have in their offices, I think there's ways to work around it, but it's something that we're discovering is more of a challenge than we were expecting when we started the project. Our hope is to get to meet with most of the different sort of isolated groups in the hospital. The one we haven't yet met with is the surgery group, but we're hopefully going to be doing that in the next week or two. And then we're planning to do a sort of staged rollout of actually activating this, screening patients and telling the services, and then moving forward with those patients being highlighted. That's the end of what I wanted to talk about.
Good evening, everybody, and thank you so much for allowing me to present my project. So as Nicole already told you, I'm a pediatric surgeon. I did my medical school and my pediatric surgical training in Italy. In 2010, I left my country to go to London, where I started as a research fellow at Great Ormond Street Hospital, and after I moved to a more clinical job at Chelsea Westminster and St. George's Hospital. And I also took a master's degree in surgical education at the Imperial College London. After in 2015, I came to Canada. I did a 1 year fellowship at Sick Kids Hospital, and after that, I moved to Winnipeg for my actual position. So I'm involved in surgical education and surgical training. Nowadays, the surgical training is becoming an issue. We got a new working hour regulation that is reducing our working time in the hospital to 80 hours. I don't know if any one of you knows Erickson and his theory on deliberate practice. This theory said that is applicable to medicine, surgery, and other domains, but to become an expert in a particular field, you need to deliberate practice for 10,000 hours. So let's focus on pediatric surgery. Actually, the program is 2 years fellowship. Without sick leave, maternity leave, without anything, we assume that we are working 52 weeks per year, 80 hours per week. We don't reach the 10,000 hours. So we definitely got an educational gap that we need to fill. We can fill this probably with simulation. Simulation training is becoming very popular and across medicine and surgery, but we got a problem. We got here a simulation center, but all these facilities are open 8 to 5, Monday to Friday, exactly in the same time where our trainees are working with us in the OR, in clinic, so they cannot get this kind of training. And also there is high cost associated with these facilities. A virtual reality simulation nowadays can cost up to $100,000. And so we got some issue for this kind of training. In 2016, Microsoft put on the market this device, HoloLens, that roughly speaking is a high-tech pair of glasses. It's a mixed reality device. It's function like a proper computer. You can put this on your head, and there are a bunch of sensors that allow you to do some great stuff, I have to say. So we can create holograms. With HoloLens, everybody can use HoloLens to bring the desktop on the wall, on the ceiling, on the floor, and play with the apps. But we can do something more sophisticated. We can animate holograms and interact with the room around us, with the object around us. So we can put a hologram on the table, and this can be animated by us. So, but how can HoloLens help a surgeon? Probably these two pictures already can suggest to you how we can use this device. Let's start with the simulation. So we can probably realize a mixed reality simulation curriculum. We can basically guarantee to our trainee to have exposition to rare condition. We can create a clinical scenario in our office with this device and guarantee them to have exposure to particular condition. This can be done in a safe environment, so before to practice on the patient, the trainee can have a virtual mixed reality experience on holograms. But most important, there is no time restriction. We can use this kind of simulation at our convenience time when the trainee is available in our office without booking simulation centers, rooms in times that we cannot go there. With this kind of device, we can have a unique learning experience, and the educational framework that we can add with this virtual environment is limitless. We probably gonna get the best teaching experience ever using this, and we want to bring this new technology to our trainee to make them better healthcare providers. So experience is at the base of the learning, so we need to fill that educational gap. According to this learning theory, a learner had to grasp experience and transform experience to create knowledge. And I want to stress on this point that knowledge can give us a better training, and better training can lead to a better patient care. So my project is mainly on simulation, but this device can be used also for other purposes. I like to speak about mixed reality surgery. So with the device, we can upload MRI and CT scan images on the device, and we can definitely overlap the images with the patient. This can be very useful for a surgeon. We can see the organs before to do the operation, before perform the incision, and we can plan even better the step of our surgery, especially in big tumors with where we can identify the vascular vessel, and that is going to be a very good step on for us. To move on, another purpose it can be a better remote consultation. We need to think about Manitoba, our geography. People are 2-3 hour fly away, and here I just put the picture as using Skype, that can help the daughter to repair a sink, but we can move to a more medical scenarios. We can discuss in a real-time patient, we can see the patient, we can suggest some procedural things to do there. At least we can even transfer the patient, but at least we got a sort of more close contact to them. Thank you very much.
All right. So how many of you have children or know someone who have children? We often take our babies home soon after they're born. We get to watch them grow. We watch them learn to feed, learn to crawl.
Okay. But imagine if your daughter spent the first 8 months of her life in hospital.
Imagine if your child was hooked up to a feeding tube for the first 5 years of their life.
And imagine if they had no interest in tasting food ever. Imagine if your baby had an ostomy, a stoma, and had to live with that until they were well into school.
Imagine your baby had to undergo multiple bowel surgeries, spending months at a time in hospital. This would affect their development, their learning, their hearing, their ability to crawl, to walk.
These are children with intestinal failure.
So we want to introduce you to our proposed project, the Manitoba Intestinal Rehabilitation Program.
So I'm Anna Scheuer, pediatric surgeon.
And I'm Jennifer Griffin, the pediatric gastroenterologist.
And we have a keen interest in this. We've both trained and worked at multiple centers across Canada, which have established intestinal rehabilitation programs already, and we're very excited to bring this knowledge here to Manitoba. So what is intestinal failure? Basically, either you don't have enough guts, or the guts that you have don't work. So the kids with intestinal failure are dependent on intravenous nutrition to survive.
Intestinal failure affects almost 25 out of 100,000 patients who are born. Our numbers are now increasing because of the improved care we can provide. And the average initial hospital stay for these patients is around 8 months. And the cost per week for these patients, just for staying in a hospital bed and receiving IV nutrition, not counting all the specialists involved in their care, is over $6,000 per week.
Okay. These kids suffer from multiple complications because of their intestinal failure. They might not eat, they might vomit a lot, they might have profuse diarrhea or bleed from their intestines. Some of them develop liver failure from the intravenous nutrition, and they need a big special IV that can become infected or develop clots, and many of these can lead to death.
So why develop an intestinal rehabilitation program? So research has already shown that having a team dedicated to patients with intestinal failure improves the outcomes for these patients. So we want them to live longer and live better.
So we've set several goals for our intestinal rehabilitation program. The first one is to achieve recognition as a consulting service, and that we're starting to do already. So we want people to know who we are, and we want to be able to give concrete examples to the teams. We'd like to develop a research database, but this is a long-term project, so not what we're focusing on through this program. And what we really want to do is decrease time to discharge. Given that we have about an 8-month average stay, we know we can do a lot better. So this is where you can help us.
So how can you specifically help? If we had someone involved in this program who could be dedicated following these children during their hospital stay, someone like a nurse educator or physician assistant, they'd be able to help us improve the discharge planning. And research has already shown that the length of stay can be reduced by up to 4 weeks for these patients and for their families. We can save money, so by shortening that hospital stay, that money saved can that be invested back into the program and help ensure its sustainability. And we can help improve patient transition to the outpatient clinics. We can coordinate with the outpatient teams, help reduce readmission to hospital.
So just so you get a sense of the numbers that we deal with, over the last 2 years, Jennifer and I have treated 32 patients at the Children's Hospital for intestinal failure, remembering that the cost of 1 week in hospital with IV nutrition is over $6,000. So if we were able to decrease the time on IV nutrition by 1 week for each of those kids, we could have saved the hospital about $200,000. So this would have been multiple days where we would have freed up a bed for other things like surgery, kids who are waiting for surgery. We would have reduced their complications by getting them off intravenous nutrition faster and had significant savings, which can be reinvested to make our program sustainable. If we were to think about the kids who go home on IV nutrition, and those we send home a bunch every year, if we could get them home 4 weeks earlier, that would be an additional almost $160,000 in savings. So this is what we can generate in terms of savings to invest back into the Children's Hospital. That's over 2 years.
So we hope you'll consider our proposal, and we hope together we can help these children live better and live longer.
Thank you.
Thank you, everybody. I'm very humbled to be here and very honored. Dr. Pilipuk graciously offered to join me, and she can help, I think, answer some questions. I'm very new at this world. I come from philosophy, as I mentioned. So this is part of my learning to learn the science, but hopefully I can show you sort of the humanistic side of this, which is why we do what we do. So I don't know if anybody can read that print, but I'll give you just a minute to. Those are 3 different stories written by parents. So if anybody's had a personal experience or has family or friends, this can be obviously very intense subject. And these are from a website that are meant for people to share their experiences. So I wanted to highlight two themes that I thought, reading through all these different comments, and I just took a few that were, I thought, good ones, but there are many that had similar themes. Parents who are grieving after a loss, they grieve like other parents who lose a child. And I think that's a misconception in these situations. So some of these things come up over and over. So perfect, my joy, my light, beautiful. She was perfect, so beautiful. They're parents too, even though their child didn't survive past the pregnancy. And the other thing, we find this so much when we see these families, is that they just don't understand why. And nobody can really answer that question for them, but so often they're searching. They couldn't understand what they could have done wrong. So a lot of times there's a sense of guilt, even if it had nothing to do with anything that they did or could have done differently. Didn't make sense, couldn't change it. So it's kind of a unique kind of grief that in this day and age is still a taboo. People don't talk about it. It's within families even, it's not discussed. So we often enter these situations, families welcome us with open arms because we're trying to kind of make sense of things for them if we can. A lot of people, I'm always surprised that they just welcome us into that situation where they're in such intense grief. And here's on that website also, they have some drawings from siblings, and they're probably sometimes forgotten in this process too. So you can see, I thought that picture up there was touching. That I think that's their brother or sister that they lost. And again, dealing with grief, these families often feel isolated. There's some advice from this other bereavement foundation that said things not to do. They also have a whole list of things to do that are positive, and there's a lot of misconceptions and these cliches. It was God's will. It was a blessing. Obviously, someone who's grieving, that's not a good thing to say. God need another flower or angel. At least, there's statements. At least it wasn't an older child or somebody passed away. You're young. You'll get over it. You can get pregnant again. All those things are obviously the wrong things to say. So in our world, so we're still part of the Children's Hospital, but we see in genetics everybody from the prenatal world all the way to adulthood. And so what we do, and this is where the collaboration comes in because we work with so many different disciplines. Dr. Pilipuk is a maternal fetal medicine specialist. So everybody gets their routine ultrasounds. If there's something abnormal, like different anomalies, birth defects, they tend to get referred to the fetal assessment units, which is a very specialized ultrasound unit with nurses doing the ultrasounds and maternal fetal medicine specialists overlooking. In certain situations, they do MRI of the fetus, and we can get into more of the details in another session. Sometimes a special echocardiogram to look at the heart. We offer in genetics maternal serum screening. Non-invasive prenatal testing is a newer technology for screening. And then more invasive ones where we can actually look at chromosomes to see if there's any extra missing chromosomes or little pieces that we can't see under the microscope with the microarray. And then often we're invited in that after they deliver. Sometimes we can tell just like examining a child who's living, we can sometimes get an idea of whether there's a syndrome and what it could be. So we do a physical examination, and this, we offer all these things, but obviously it's completely voluntary, and we like to empower people to make decisions. If there wasn't a source of DNA from the amniocentesis, if that wasn't done, then we offer to take some tissue and store some DNA in case there's any tests that we could do. We always offer, again, and parents can obviously decide not to do this, but if they want full autopsy, if they don't want autopsy, then there's this newer thing in the last 10 years where we call it a non-invasive autopsy, just take x-rays, do MRI, and rarely we find an answer. So that's the truth. So there's some syndromes that are more common. If we don't find those, sometimes we get a clue from all these things, and a lot of times we don't, and we fall short, unfortunately. So we say unexplained pregnancy loss, but sometimes it's unexplainable is the answer, unfortunately. So rarely we can get funding to do testing if we have some specific things in mind, either certain genes or a panel of genes. But right now we're not set up to do more. So this is why this project was created. This is the result of the Human Genome Project. It seems like a long time ago now, especially at my age. But there was a lot of excitement. I mean, half my life ago or so. But I don't know. Something in that realm, but this is the fruit of that labor is to make new discoveries. And instead of looking at one genes or a panel of genes, in an unbiased way, we can look at all 20,000 genes at once. We can do this test now on a clinical basis. Sometimes we can get funding, but in the prenatal area, we don't really have access to funds because there are other priorities. which is understandable. The prices come way down, obviously. So, I mean, that's in pounds. But if we do it on a research basis, we can do a whole genome or whole exome, which is similar. We can do that for around $1,000 now, which is incredible because this is used to cost billions, millions, hundreds of thousands. It's really dropped in price, so it makes this kind of project doable. And this is just showing a schematic. We can go into more detail another time, but we get DNA, chop it up. It's in these little fragments, and the fragments are red. They overlap, and it's like putting a puzzle together. We get a sequence of the entire genome, which is pretty incredible. The difficulty now is what to do with all that data. That's where the interpretation side is difficult, but also an opportunity for discovery. The other part of our project, this was kind of a happenstance thing. We found out the small animals lab just got a new fancy MRI called a 7 Tesla MRI, which is a lot more powerful than standard MRI. It's just being used now in clinical applications. I think Harvard has one. It's really rare to actually have it used for patients. They have it for mice and rats, but it kind of works for them and it works for us if we can use in this scenario in an early pregnancy loss. Because for them, it's more justification for having the machine, and for us, the machine isn't being used most of the time. So these are just some images. You can see like the blood vessels are so detailed here compared to a normal MRI. And obviously, we couldn't do functional study after a pregnancy loss, but this is just showing the heart, and you can actually see the blood pumping on MRI, which is incredible. I think it's so detailed. A lot of times in early pregnancy loss, autopsy isn't that helpful because things haven't really developed. So there's potential to discover new things about early development that we don't know about. So that might help these families, but it also might help advance the science. And this is our team. So Dr. Frosk is in here. But really, once I got that micro grant, I started approaching people, and with the help of Dr. Frosk. And we have buy-in from so many different people. We basically have everybody ready to go. We have to get ethics approval, obviously. I'm on the REB also. But I wouldn't be involved in approving my own project. That wouldn't be ethical. But we're ready to go. We just, in order to scale this up, we asked for funds. And I know I'm going to get a question about how much it costs. We can scale it up as far as we can go, essentially. I call this the 10 genomes project because there's 1,000 genomes project, so it kind of pales in comparison. But we could go from there. We could go further if we get more funds to do it.
The sad reality for us is that in fetal assessment, with about 10,000 deliveries in Manitoba, there's one of 6 of us who cover all of Manitoba, Northern Ontario, and Nunavut. We see a family a week at least who's experienced a late pregnancy loss. And of the 10,000 deliveries we have in Manitoba, 1 in 4 of those actually result in a pregnancy that was actually lost much earlier. Tyler already alluded to the fact that this is a very difficult conversation. You go into medicine to want to help people and help families. You fall in love with high-risk obstetrics, and very quickly you realize anyone who's referred to see you, they don't want to be seeing you. There is a complication that's already been highlighted, which is what brings them to our doorstep. And as part of the International Society for Obstetrics and Gynecology ultrasound, they've identified stillbirth, late stillbirth, as probably one of the greatest devastations in medicine where we've made very little progress. Where if someone had an autopsy as an adult, a family would expect some answers from that. In childhood, if there's a passing of a child, we usually get an answer. And for 1 in 6 families who've experienced a stillbirth, we have an answer for them. 5 out of 6 families, all of our investigations that we're able to do with the standard panel, standard blood work, yields nothing. So it impacts the family, the siblings, the future pregnancies. And whereas this technology, we think, would probably improve diagnosis, perhaps 4 to 5 out of 6 of those losses. A combination of the genetic testing that Tyler has experience with, Jens Rogeman, who's a pediatric radiologist who'll be looking at this micro MRI technology, really have the potential to revolutionize diagnosis for this family, future pregnancy planning, extended family planning, and offer answers to Manitobans who really do need it, and also assist us in medicine who really want to help. So we think that probably within 2 years, we would be able to have enough of a powered study that would show that this perhaps should be something that we should offer, Everyone's very aware that it's very lean times in Manitoba when it comes to healthcare dollars, but hopefully with some seed money to start a project, we can show that this actually is very relevant and it's timely that it be done.
I'm going to tell you a story. Okay. It's a story about a couple of women I knew very well. They're sisters-in-law and they're pregnant at around the same time and they're expecting their babies, and you plan on the kids growing up together and playing together and all of that. And so the first one goes into labor and she's tiny, so this is not a small baby. So she is pushing and the baby gets stuck. And so the obstetricians roll up their sleeves and get to work, and they apply forceps and they pull and they pull, and the baby comes out and everything's okay. And so her sister-in-law goes into labor, and she's also tiny, and so she's starting to push and the baby gets stuck. And so the obstetricians apply forceps, and we think the same thing's going to happen again. They're pulling, and the baby's still stuck. And so then they're pulling, and the baby's still stuck. And you remember when a baby is being delivered, the umbilical cord is compressed, so there's no breathing going on right now. And they're still pulling. And finally they get him out, and he tries to take a breath, and he stays blue. And he died 3 days later of pulmonary hypertension. It's a blue baby. Why am I telling you this story? The first baby was me. The second baby was my cousin. Pulmonary hypertension, blue babies, is that commonplace and that devastating that you'll find this happening in everybody's family. It has an incidence of maybe 6 per 1,000. That's maybe 30 babies in Manitoba per year. It's 10% of our ICU admissions. But when it's your baby, it's the universe. This is the problem. Until you're born, mom's doing all the breathing. You don't have to use your lungs at all. At the minute you're born, when you take that first breath, suddenly now your lungs have to come online. And your heart has to pump blood into your lungs so that when you take a breath, the blood comes into your lungs to get that oxygen. And oxygen is the trigger for all of this. But in a baby who has difficulty during delivery, isn't born smoothly, and doesn't get enough oxygen during that delivery, all of those triggers don't happen. So the blood vessels in the lungs stay tightly constricted. They go into spasm. And breathe as hard as you might, you will not get any oxygen. That baby will not turn pink. Now, as a doctor working in the intensive care, these are the sickest babies I take care of. These are the ones that keep me up all night. Because we have a few drugs that will relieve the spasm of blood vessels in the lungs, but they don't always work. So we'll try the first drug, and when that doesn't work, we'll pull out the second one, and then the third one. And I'm relying on the scientists to fill my back pocket with drugs that actually work. Because if they don't work, I feel helpless. And I don't have a lot of time, because these babies, if you cannot get blood flowing into their lungs within the first week of life, they will die before their second week of life. So as a scientist, this is what I study. And looking at the drugs that we use, almost all of them work through pathways that converge on one molecule, a gatekeeper molecule. It's called adenyl cyclase 6. The name's not important. That gatekeeper molecule allows all of these drugs to actually take their effect. But what we discovered was in conditions of low oxygen, that gatekeeper molecule stops working, which means none of our drugs are going to work. So what we've been looking at is exactly how the lack of oxygen stops that molecule from working. And I think we've got it now. We understand the shape of that molecule. We understand where its on switch is and exactly why that on switch doesn't work under conditions of lack of oxygen. And so how could you turn it on? This is what we're trying to do. We've designed a drug that will actually fit into that on switch and activate the gatekeeper, which then means all of our drugs would start working again. So the deliverable on this project is the synthesis and testing of that drug to activate the gatekeeper in order to relieve the blood vessel spasm in the lungs of these babies, and eventually, so the blue babies will turn pink. That's what I've got for you. Thank you very much for listening.